understand eye movements in a simple and logistical manner. For that, we are basically going to use a very simple approach. The basic tools we're going to use is 2x and this arrow. So with just these three tools, or the two tools, the X and this spatula, we should be able to figure out how to sort out eye movements. And at the end of the session, you should feel that eye movements and nystagmus are beautiful. And just in the name of diversity, beautiful in both ways. Okay, so let's start. So this woman has got problems with her vision. Okay, as you can see, I just want to make sure that I'm not muted accidentally. Okay, okay. So you can see from the reflection of the ambient light that this light here, the ambient light is reflected right spot on in the center, but this is slightly off center, which tells us straight away that there is something wrong with the orientation of the visual axis. So one eye is either abducted or adducted at rest position. So to confirm that, if you move the eyes in the primary positions, which is up, down, left, right, you notice that the abnormality is most obvious when the patient looks to the left. And you can see here clearly the reflection of the light is here. Here the reflection is the light is here. So clearly this eye is not abducting as much as it should. So how would you approach this in the name of what I just said? So basically you draw 2x, okay, 2x like this. And then you'll draw the two arrows. In this particular case, the two arrows that are not working, of the two arrows, the arrow that's not working is this one, correct? So the next diagram should look like this, okay? Then when you connect these arrows to the relevant nerves, you get something like this, correct? So then you realize that the pathology can be in the muscle that is preventing this eye from abducting. It could be in the neuromuscular junction. Therefore, this eye is not able to abduct, or it could be in the nerve. And if it's the nerve, it is the sixth cranial nerve, correct? So that's how you would approach this patient's problem. Now, if it is indeed, if you have thought about this patient carefully and you ruled out muscle, a localized muscle pathology like a restrictive problem. Restrictive problem means the muscles are fibrous. So this muscle is supposed to move to the left, this muscle is supposed to move to the right. So if one muscle is super fibrous, it's not going to allow the other muscle to move, right? So this is what we call restrictive ophthalmopathy. So localized muscle disorders, like for example, in thyroid eye disease can do that, okay? So if we have ruled that out, and then if we have thought about neuromuscular junction and ruled out by looking for signs of fatigability, then the remaining cause is the sixth cranial nerve, correct? So if it's sixth cranial nerve is a, sixth nerve is a cranial nerve, right? So straight away you have to invoke the laws of cranial neuropathy. So the 4+1 rule. So in this particular case, you have to examine the patient carefully. She couldn't abduct the eye to the left, right? So she could have a left sixth nerve palsy. If she does have a left sixth nerve palsy, maybe it's in the left pons. How would you know it's in the left pons? Because she would have other cranial nerves that are coming from the left pons. She would have drowsiness. And if you examine the limbs, she would have signs of pyramidal and cerebellar signs that will point towards a brainstem localization, okay? Now, if it is not in the brainstem, then it could be one of the cranial nerve clubs. And we've already discussed this before. Sixth nerve is associated with two prominent clubs. One is the orbital apex superior orbital fissure club, or the other one is the cavernous sinus club. In the orbital apex superior orbital fissure club, you have the second nerve, the sixth nerve, the fourth nerve, the fifth nerve, and the third nerve, right? So the second and the fifth nerve joins the oculomotor nerve as well as the fourth and the sixth nerve, okay? In the cavernous sinus, the second nerve is not there, but the fifth nerve is very prominent there. Bigger components of the fifth nerves are there, okay? So therefore, you would examine this patient carefully for the second cranial nerve, which means you look at the pupillary response carefully, you look at the visual acuity carefully, make sure second nerve is not involved. And then in the eye movements, you've done the cross, but you should now subsequently go and do the H and look carefully for evidence of fourth nerve problem or third nerve problem that's associated with it. And finally, you'll examine the patient's facial sensation and corneal reflex to see whether the fifth nerve is associated. And if it is indeed affected, then you would invoke the possibility of this being a cavernous sinus club. Now, the next rule of the cranial nerve tells you that during your cranial nerve examination, you have to think about and rule out actively evidence of meningeal disorders like meningitis or skull base metastatic disease, right? Skull base metastatic or some other pathology in the skull base. So you will look for headache, neck stiffness, lymphadenopathy, fever, headache, vomiting, and all the other symptoms that will suggest meningeal and skull base pathology. And then finally, we know that after you finish your cranial nerve examination, as you go to the limbs, just like you look in the limbs for evidence of brainstem dysfunction, meaning upper motor neuron signs in the limbs, you would also think about ruling out peripheral neuropathy like Guillain-Barré syndrome actively by looking for evidence of areflexia, ataxia, and sensory loss, which would suggest a diagnosis of peripheral neuropathy or one of its the diagnosis of peripheral neuropathy, specifically Guillain-Barré syndrome or one of its variants. So in Guillain-Barré syndrome, there are many variants. One of them is associated prominently with eye movement abnormalities, the so-called Miller-Fisher variant, and that is associated with distal sensory loss, distal areflexia, as well as ataxia in the limbs. Okay, so you need to look out actively for these signs. Then only after you've ruled out all these things, then you may want to consider whether this patient's sixth nerve palsy is due to an isolated sixth nerve palsy from a diabetic patient having an ischemic sixth nerve palsy. Okay, this is the most important cause of an isolated, and indeed, only after you've thought about all these things actively, rule them out, then you can invoke the +1 rule. Okay, if it's truly isolated, then you have to think about this. But even then, you realize that some of the conditions that we talked about, here, reappear here. For example, meningeal causes, raised intracranial pressure, cavernous sinus, because in the early stages, sometimes it's an isolated sixth nerve palsy. But later on, maybe the third nerve, the fourth nerve, and all the other signs will come. So you still need to keep an open mind about the other causes. But if it's truly, truly an isolated sixth nerve palsy and remains isolated sixth nerve palsy, then we are dealing with a diabetic patient with ischemic sixth nerve palsy. Okay. Now, in this particular case, this patient, in addition to the sixth nerve, in addition to the abduction deficit, had decreased sensation of the left face. She also had decreased corneal reflex. Okay, a second cranial nerve was affected because when we tested a visual acuity was much reduced compared to the other side. So in other words, she has a second cranial nerve, she's got a sixth cranial nerve and a fifth cranial nerve. So this localizes to the orbital apex, and indeed you can see the redness of the eye, and that's because she has got this unusual condition where the carotid artery communicates with the cavernous sinus, and the cavernous sinus blows up, okay, with arterialized blood, and the blood is transmitted forward to the orbital fissure, orbital apex. So she gets a combination of signs from both the orbital apex as well as the cavernous sinus. So she's got sixth nerve, fifth nerve, and second cranial nerve. And with time, she would start to develop other cranial nerves like the fourth and the fifth nerve, unless this problem is addressed. Basically, the carotid artery, which is sitting next to the cavernous sinus, instead of being a discrete structure, it forms a fistula. So the carotid artery now is pumping arterial blood into the cavernous sinus and arterializing it. So that's why these patients develop severe pressures in the cavernous sinus and orbital apex, developing second cranial nerve, sixth cranial nerve, fifth cranial nerve, occasionally fourth cranial nerve, third cranial nerve, and all the other signs associated with it. And then, of course, the congestion and redness of the eye is due to the venous hypertension that occurs when the artery connects with the cavernous sinus. Okay, so this particular patient, final localization because of the combination of cranial nerves was in one of the clubs. In this case, combination of both orbital apex and cavernous sinus. And that the reason we were clued into the diagnosis because she had the associated cranial nerves, which is second, fifth, together with the sixth. And with the redness of the eye, we went on to image her and found that there was a fistula in the carotidocavernous region. Okay, now let's go to the next patient. So if you can see this picture, you can see that there are a lot of things happening, but the most important thing is to remember what you want to draw in terms of the egg diagram. So remember, you need to draw an egg diagram like this. So one second, just make sure that my here communication in my son. Okay, so let's start again. So you remember, you're supposed to just remember to draw the egg diagram and figure out which one is not moving. Okay, so in this particular case, if you look carefully, okay, this eye is not adducting when he looks to the left. When he abducts, when he looks to the other side, both eyes are able to abduct and adduct very well. But when he looks to this side, this eye is not adducting, this eye is abducting very well. So if you were to draw a simple egg diagram, you will realize that in this direction to the left again, just now the patient's problem was in this arrow. Now the problem is in this arrow, correct? Okay, so if you connect this up again, this is the third cranial nerve and this is the sixth cranial nerve. So again, you have to start thinking about what are the possible causes of this redness here. It could be a localized muscle pathology in this muscle that is causing adduction. Just now it's the lateral rectus muscle. Now it's the medial rectus muscle. It could be again a neuromuscular junction problem. It could again be a third cranial nerve problem because we haven't really tested all the other eye movements. So he could easily have a third cranial nerve problem. But in addition, you realize there is a problem in this diagram because the third cranial nerve lives in the midbrain. The sixth cranial nerve lives in the pons. Okay, so the pons is here and the midbrain is here. So this is on on a different floor. If this is a apartment complex and this guy is living on the sixth floor, this guy is living on the third floor. So how is this guy going to communicate with this so that these two movements are simultaneous? These two movements are simultaneous. Obviously, there must be an elevator that will connect the sixth cranial nerve to the third cranial nerve. This elevator is known as the medial longitudinal fasciculus. Basically, it's a myelinated trunk that conducts information from the sixth cranial nerve to the third cranial nerve so that they can both fire together. Because if they don't fire together, if this guy fires on his own and this guy fires his own, this patient is going to get double vision, right? So the medial longitudinal fasciculus ensures that when the patient looks to the left or right, the sixth and the third cranial nerves are coordinated. Now, so you realize that if this is the case, this redness of this arrow could be due to a muscle, neuromuscular junction, nerve, okay? But in addition, it could also be the problem in this elevator, correct? It could be a problem in this elevator. So a problem in this elevator is known as internuclear ophthalmoplegia. Why is it called internuclear ophthalmoplegia? Because it is an ophthalmoplegia that occurs because there's a communication block between the sixth cranial nerve and the third cranial nerve. So you realize that this patient's problem now could be a muscle problem, okay, localized muscle problem, restrictive muscle problem like thyroid disease, could be neuromuscular junction problem, okay, could be it could be a third cranial nerve problem, okay, or it could be a problem in the communication between the sixth and the third cranial nerve. Okay, so these are the various causes that you have to think about. Now, so in this particular case, of course, we went on to examine this patient. Okay, we examined his all eye movements and the pupils also we checked. So there was nothing else that was wrong with the third cranial nerve. So we don't think that this adduction deficit is due to a third cranial nerve problem. We also looked carefully for evidence of neuromuscular junction pathology like fatigable ptosis, and there was nothing to suggest neuromuscular junction problem. And then we examined this patient's orbit carefully, and there was nothing to suggest a problem of restriction like thyroid eye disease. Thyroid disease is a classic cause of restriction of the eye movement or restrictive ophthalmopathy. So there was nothing to suggest that. So then we started considering whether this patient's problem could be in the medial longitudinal fasciculus, okay, suggestive of internuclear ophthalmoplegia. And that's when we realized that there was one other physical finding that was very interesting. And that is the right eye that's abducting very well, doesn't just abduct, but it also seems to be having a bit of eye movement, which is basically a spontaneous eye movement with a fast phase and a slow phase, a fast phase and a slow phase, a fast phase and a slow phase, right? So that is a nystagmus, but the nystagmus is occurring only on one eye. Okay, this eye, this so-called abducting nystagmus, okay, tells you that the pathology is likely to be in the medial longitudinal fasciculus. Why do we say that? Because what happens is, in this particular patient, this eye is supposed to look to the left, correct? It's supposed to look to the left. Now, at this point, when you're supposed to look to the left, this eye is able to abduct, no problem, because the signal is getting through. But this signal is not getting through, right? It's getting blocked here. So what does the brain do? It sends more signals down. The more signals that are sent down is able to go to this eye without any problem, but still gets blocked here, okay? But then what does the brain do? It sends even more signals. Now it sends 3 times the amount of signals. The 3 times the amount of signal is still sent to this eye, but the block is still there. So therefore, even though it's 3 times the signal doesn't get through. Okay. So in other words, the 3 times signal doesn't get through. But this poor eye here now is getting 3 times the amount of signal that it normally needs. So what's going to happen to the eye? Obviously, it's going to overshoot the target. Okay. So this overshooting is the fast phase that you're seeing. Okay. Overshooting and then it comes back. Overshooting and comes back because the signal to this eye is 3 or 4 times the signal that was meant to be given to it. Because of this block, the brain keeps sending in more and more signals. So the over stimulation of this eye results in this eye overshooting. And when the overshoot stops, it comes back. It overshoots and then it comes back. It overshoots and then it comes back. It overshoots and it comes back. And then when you look at it from far, it's a classic nystagmus because there's a fast phase and then a slow phase. Fast phase and then a slow phase. Fast phase and then a slow phase. Okay. So that is the classic abducting nystagmus that you see in internuclear ophthalmoplegia. So with the exclusion of localized muscle disease, with the exclusion of fatigability, with the exclusion of other eye movement abnormalities associated with the third nerve, and with the presence of this abducting nystagmus in the other eye, we concluded that this patient's problem is a lesion in the medial longitudinal fasciculus, and the pathology is known as internuclear ophthalmoplegia. Okay, now, so that's what he has. Okay, now let's move on. So this is another patient that looks very complicated, but again, remember, I want you to just like we do for our weakness formulas and various other formulas, we have to go step by step. We have to go step by step. So we break down one step and then we go to the next step. We break down one step and then we go to the next step. Okay. So in this particular case, the patient was looking to the left and then looking to the right. So all you need to do is decide on the egg diagram which arrow is not working. Okay. So now let's play it. Don't worry about all the vertical eye movements. Just we're only considering horizontal eye movements now. So, okay. So if I were to just make it simple for you and break it down in 2 steps, okay? Now she's going to look to the left, okay? Okay, which eye is not moving? This eye is not moving. So your arrow should look like this, okay? Now, if I let the video play so that she can look to the other side, let's see what is not moving. Then you realize, oh, this is not moving, okay? Okay, if you don't believe me, you can play it again. So when you look to the left, this eye is not moving. So we drew that arrow as red. But when you look to the right, this arrow is not moving. So in other words, for the looking to the right, this arrow should be red. Now, if you put these two diagrams together, you get a composite diagram like this, 2 red arrows like this. Now we sit down and think about it systematically. Could this be a muscle problem? Yes. But then how can you think about a muscle disorder that is so selective that is only affecting 2 of the adducting muscles? Okay. So thyroid eye disease can cause restriction of various muscles, but for it to affect just 2 muscles, and as you can see, there's no other signs of thyroid eye disease like hyperthyroidism signs like little retraction, little lag, and all these things. So I think we can safely conclude that it's not a muscle problem, right? It could be a neuromuscular junction problem, definitely. Okay, it could be a neuromuscular junction problem. This lady could easily have myasthenia gravis, and if we go on and examine other signs, maybe she will have fatigability. Okay, now she could have a bilateral third nerve palsy, possible, right? Bilateral third nerve palsy, but you would expect other eye movements to be abnormal at the same time. But then you realize that in addition to these 3 entities, the 2 elevators are actually next to each other in the central area of the brainstem, right? From the pons up to the midbrain, the 2 elevators are traveling next to each other, okay? They are forming 2 parallel tracks. So you can't, it's not inconceivable that there is a small lesion that straddles the midbrain and affects both medial longitudinal fasciculus. A small lesion that is affecting both these tracts in the central part of the brainstem. Okay, you can think of various pathologies, whether it's a brainstem tumor, this a demyelinating lesion in the brainstem, or whether it's a basilar artery. As you know, basilar artery, we discussed a patient with basilar artery stroke last week. A basilar artery is right in the center, so it innervates both parts of the brainstem. So a basilar artery disease could easily cause this. A demyelinating plaque that's sitting here exactly where this lightning bolt is could demyelinate both these tracts and cause the same kind of pathology. So this lady could easily have bilateral medial longitudinal fasciculus lesion. So the differential diagnosis are, number 1, a low probability of this being a restrictive muscle problem. Number 2, a real possibility of this being myasthenia gravis. Number 3, a moderate possibility of this being bilateral third nerve palsy. Okay, and a real possibility of this being bilateral medial longitudinal fasciculus. So what could we do to differentiate between these 4 entities? Okay, in the next video, you will see one particular maneuver that's being conducted that will help you differentiate between the 4 entities. Okay, I'm just going to let the video run. She looks to the left, we saw the deficit. She looks to the right, we saw the deficit. And then now I'm going to ask her to converge on my pen. Then suddenly the muscles that were weak seems to be moving perfectly well. Okay, now we go back to this diagram again. Okay, now if this was a muscle disorder, could it be overcome by convergence? No, because the muscle, if it's restricted, it will be restricted no matter what you do with the eye movement. So the fact that it's overcome by convergence means it cannot be a muscle problem. Can it be a myasthenia? Cannot be myasthenia again, because if it's myasthenia, again, because the neuromuscular junction is faulty, the eye movement, the adduction will be weak, whether you're asking the patient to look left, look right, or converge. Whatever the stimulus, the same problem will exist. Likewise, if it's a bilateral third nerve palsy, whether the patient is asking to look to the left or look to the right or converge, the same movements will be abnormal. But in medial longitudinal fasciculus lesion, possibly, if you think a little bit about what you remember from anatomy days, you know that the third nerve is in the midbrain, okay? The sixth nerve is in the pons, right? And the medial longitudinal fasciculus is traveling all the way from up here, all the way to the third nerve. Now, if there's a lesion in this tract here, okay, now it's going to affect this ability to look left and look right. But what about convergence? Now, if you realize convergence is not the same thing as looking left and looking to the right, you may have realized, and now if you look at my video, look straight at my face, I'm able to look to the left, I'm able to look to the right, I'm able to look to the left and right in response to an external stimulus, or I can voluntarily also move to the left and right on my own. Okay, that means I can even move the left and right with my eyes closed or in darkness. Even with my eyes closed, I can move my eye to the left, I can move my eye to the right. Okay, no problem. But convergence, on the other hand, is a very different eye movement. Okay, it looks the same, but it's not the same. Okay, it firstly requires a stimulus. You cannot converge your eyes without a stimulus. You can try now. You try to converge, no matter how hard you try, you cannot bring your two eyes together. But the moment you fixate on an object, you can converge. Right? I'm converging now, right? I'm converging. I'm only able to converge because I've got an object, which means when I close my eyes, I cannot converge. When in the darkness, I cannot converge. So you realize that convergence is a completely different eye movement from horizontal saccades that is controlled through the medial longitudinal fasciculus. And indeed, convergent fibers have got a slightly different pathway and they go directly to the third nerve. They go directly to the third nerve. So a lesion in the medial longitudinal fasciculus may not affect the convergent fibers because the medial longitudinal fasciculus lesion is here. The convergent fibers are going straight to the third nerve in the midbrain. So in this particular case, this lady has got a tumor in the pons that's demyelinating the medial longitudinal fasciculus in the pons. So therefore, when she looks left and looks right, she's got bilateral INO. But in the midbrain, her third nerve nucleus is perfect. So she's able to, the convergent fibers are directly going to the third nerve nucleus in the midbrain, and she's able to converge beautifully. And with that, we know for sure this patient can only have bilateral MLF or bilateral internuclear ophthalmoplegia as the cause of a problem, because muscle pathology, neuromuscular junction pathology, bilateral third nerve pathology cannot possibly explain this discordance between lateral eye movements and convergence. Okay, now I'm going to pause here and allow questions. If not, we'll go on to the next question, next case.
Hi, Prof.
Yes.
Hello, can you hear me?
Yes. I can hear you well. Question?
Oh, yes. So I was wondering, sorry, what exactly do you mean by the restriction in the hyperthyroidism? Like, what exactly does that mean?
So in hyperthyroidism, the muscles are restricted because they are fibrosed. So therefore, if you go and read your chapter on thyroid eye disease and what happens to the muscle, there will be a lot of explanation about what is the pathology and thyroid eye disease. It's beyond the scope of this lecture, but we must remember that it's thyroid eye disease is an important cause of ophthalmoplegia, but the ophthalmoplegia is not due to a nerve problem, It's not due to the neuromuscular junction problem. It is the muscle itself that's fibrous, and once it's fibrous, it's not able to function well. Okay, so the term we use is
Okay.
restrictive ophthalmopathy, as opposed to muscle,
Oh,
as
that,
opposed to
yeah.
nerve problem or neuromuscular junction problem, where we use the word, where we don't use it, but we imply the term paralytic ophthalmopathy. In thyroid eye disease, the muscle is restricted, therefore it cannot move freely. Okay, so again, please do read about it. It's an important internal medicine topic that you may need to know. Okay.
Sure. Thank you so much. Yeah.
Hi, Prof. I've got a question. So you mentioned that like for INO, you get the classical nystagmus. So if it's bilateral INO, will you get like a bidirectional nystagmus?
Yes, indeed. If you look at this lady carefully, you may perceive a little bit of this there. Can you see that? Can you see that? So she does have it. It's a little bit complicated because there seems to be a vertical component to it, but majority of the nystagmus is beating towards this direction. So indeed, it's a good question. And let me just play it again to show you that when she looks to the left, this eye is abducting a bit, abducting nystagmus here, and this eye is having abducting nystagmus. So the normal contralateral eye that is fully abducting gets too much of stimulus, so it overshoots the target and it manifests as a abducting nystagmus. Okay. 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 So while the rest of you are thinking about questions, the next one is actually a quiz. Or no, actually not a quiz yet. There's one more thing, then we'll give you a quiz. Okay, so this lady is unable to look to the left.
Look to the right.
No problem.
Now look as far as you can to the left.
Okay, now she's trying to look to the left, as Dr. Z is trying to say.
Right. And as far as you can to the left.
Nothing is moving. So again, you may think of various diagnoses, but again, as I've always been emphasizing from the very beginning, whether it's weakness, blurring of vision, cranial neuropathy, always use a formula, right? So in this case, use the X, even though you think that you know the answer, do the workings properly. So in this case, if you draw the X, 2 arrows to the left, 2 arrows to the right, no problem, right? She can look to the right, no problem at all. When she looks to the left, what happens? Both arrows are red, correct? Now, so then you just connect up the lines. So this arrow, lateral rectus muscle, connect to the 6th nerve, all the way to the 6th nucleus in the pons. This one is connect to the 3rd nerve, all the way to the 3rd nucleus in the midbrain. And then, of course, you have the elevator that connects the 2 of them. Okay. Now, even if you have absolutely no knowledge, in fact, if you have a non-medical person in your household, you can show this picture, ask them to do like a puzzle. Where can you put a cross? You know, like pinning the tail on the donkey kind of game. Where can you put a cross in this diagram to allow both these arrows to become red? Where can you put a cross? Okay, if you put a cross in here, this will be red, but this will not be red. Okay, in the first patient, we put a cross here. This was red, this was black. Okay, but how can we make both of them red with just one cross? Obviously, many of you would now understand that you'll have to put a cross on the 6th nucleus itself. Now, at this point, you realize that the 6th nucleus, remember last week we discussed the problem with the 3rd nerve. The 3rd nerve, when it becomes the nucleus, in the nucleus itself, the structure of the nucleus is more complicated than the nerve itself. So likewise, the 6th nucleus that's located in the pons, not only does it have cell bodies that control the 6th nerve, but it's actually controlling the whole of gaze to the left. So therefore, a synonymous name for the 6th nucleus is the lateral gaze center. Okay, synonymous names. Okay, so 6th nerve, like the first patient, remember the very first patient with the carotidocavernous fistula 6th nerve lesion. Okay, she only had problem in the 6th nerve, so only this eye wasn't moving. But if the 6th nucleus is affected, not only is this eye not going to move, the whole of gaze is affected. So therefore, when it's a 6th nucleus problem, we call it the lateral gaze center problem. Okay, so you would put an arrow here, and that will elegantly explain what this patient cannot do.
Camera. Look to the right. Now look as far as you can to the left. Right. And as far as you can to the left.
So therefore, she has a lesion in the left pons, okay, affecting the left 6th nucleus. Now, many of you will be wondering then, how come we are only talking about the brainstem? There must be control of the eye movements from other centers, right? Because brainstem is a reflex center. There must be higher cortical control. For example, our ability to move our eyes is just like any other action, right? We have voluntary action. I want to move my right hand. I want to move my left hand. Okay. A lot of the reflex of the right hand and the left hand is in the spinal cord and the cervical segment, but the control of volitional movement comes from the cortex, right? From the frontal lobe specifically. So likewise, how do we voluntarily control eye movements? We must have control coming from the frontal lobe, which is the area where you decide what you want to do with life. Okay, it's where your volition is. In other words, where your soul is, S-O-U-L and not S-O-L-E. S-O-U-L is cited in the frontal lobe. Okay, so whether you want to dress today like this, or you want to drive this car, you want to marry this person, all this is decided by the frontal lobe. Okay, that's where you initiate voluntary action. So this lady wants to move to the left and right. Obviously, the stimulus must come from the frontal lobe. Now, so far, everything I've given you, most of the knowledge is very basic. In fact, you can work it out. Nothing is memorized, right? I don't think I've given you anything that requires memory work. But this is the first thing that I need you to memorize. And the first bit of information that I need you to memorize, because we don't really know why this is happening, that's why we need you to memorize, is the frontal eye fields are crossed. Okay, crossed. So why the frontal eye fields are crossed, nobody knows, but the frontal eye fields are crossed. So in other words, if you want to look to the left, it is the right frontal eye field that sends a signal to the 6th nucleus to move the eye to the other side. Okay, it is the right frontal eye field. So similarly, if I want to look to the left, it is the right front. Sorry, if I want to look to the right, the left frontal eye field will send a signal to my right 6th nucleus to initiate the movement. The 6th nucleus, remember, is the gaze center, right? So in other words, this frontal eye field is initiating impulse to this gaze center to initiate this movement. So now you realize that this lady's inability to move to the left, okay, because of the 2 arrows that are red, could be a lesion here, okay, to make this arrows red. It can be a lesion here. But you realize that with this frontal eye field being involved, okay, the lesion could also be here. These will look the same as far as the eyes are concerned, correct? So right frontal eye field will cause inability to look to the left. Left pontine lesion affecting the left 6th nucleus will also cause inability to look to the left. So this lady's pathology could be either in the right frontal eye field where my arrow is, or in the left pons. 2 things will look exactly the same in the picture. And because you only see the 2 eyes here, okay? You don't see anything else in about her. But so how do we differentiate between the 2? Well, it's quite easy actually. The moment, if let's say this is the pathology is here, okay, as opposed to here. Now, as you walk into the ward, okay, this patient with the right frontal eye fields would have pathology in the limbs also, right? Because the frontal eye fields are in the frontal lobe. Frontal lobe doesn't only have eye movements, right? It also has your limb movements. So which side is going to be paralyzed? The left side is going to be paralyzed. So as you walk into the ward, as you see this patient from far away, you'll see that this lady has paralysis of the left side. But as opposed to this patient, okay, when she has a lesion in the left pons, where would a limb paralysis be? Right side, correct? So both instances, the eye movement abnormality, this one and this one, the eye movement abnormalities are the same, but the limb weakness is different. And it's so different that even from a mile away, you'll be able to diagnose it. In this lady, the patient cannot look to the left and her left side is weak. In this patient, she cannot look to the left, but her right side is weak. So straight away, you will be able to differentiate a frontal eye field lesion from a 6th nucleus lesion from far, far away. But of course, we don't do clinical medicine from far away, right? We come to the bedside. At the bedside, you'll see additional findings. For example, this patient, okay, what kind of appearance will she have on her face? Now, in this case, you cannot see a face, right? You can't see a facial appearance. But let's say I open up this screen and allow you to see the face when you come to the bedside, okay? If there's a lesion in the right frontal eye field, what kind of facial palsy will she have on the left side? She will have a upper motor neuron facial palsy on this side, correct? Upper motor neuron facial palsy on the left side. Now, on the other hand, if she has a lesion on this side, she has a lesion on the left 6 nucleus. 6 nucleus is links to the 7th nucleus. So what kind of facial palsy will she get in this particular instance? She'll get a left lower motor neuron facial palsy. Now you have 2 tools to differentiate between frontal eye fields and frontal eye fields and 6 nucleus lesion. Frontal eye fields or 6 nucleus lesion. Frontal eye field lesion on the right side will cause left hemiplegia and left upper motor neuron facial palsy. A lesion in the left 6 lateral gaze center will cause right hemiplegia and left lower motor neuron facial palsy. So straight away, you'll be able to differentiate the lesion here and here, not from the eyes, but for looking for other associated signs, because eye movement abnormality will look the same. Correct? The eye movement abnormality will look the same. Okay? So in other words, this lady's lesion could be in the right frontal eye field, which means I will have to open up the screen and look for left facial, upper motor neuron facial weakness and left upper limb and lower limb hemiplegia. If she had a lesion in the left pons, when I open up this screen, I will see that she has got left lower motor neuron facial palsy and right upper limb and lower limb hemiplegia. So straight away, I'll be able to tell you the 2 different causes of this lady's left gaze palsy. One is supranuclear, one is nuclear. Okay. Now, you would have seen patients like this in your ward. Now, many of you would have seen patients with frontal lobe infarction, right? Middle cerebral artery infarction. And you realize that in the wards, people always talk about the eyes deviating towards the side of the stroke. You're not surprised, right? If there's a lesion here, the eyes cannot move to this side. So when given a chance, the eyes will drift towards the side of the stroke. So many times in your right MCA stroke patients, if you lift up the eyelids, in fact, when you go back to the wards later on, find an MCA patient. This right MCA stroke, you lift up the eyelids, the eyes will be at a rest position, will not be at rest, you'll be pointing towards the right hemisphere. If the patient has got a left hemispheric stroke, the eyes will not be able to look to this side. So at a rest position, the eyes would have quietly drifted to the same side of the stroke. So in other words, the way to remember is the cortex is the seat of your soul, remember? So it doesn't lie. It is morally very upright. Okay, it will tell the truth. So when there's a stroke, the eyes are pointing towards the side of the stroke. Always pointing towards the side of the stroke. So that's how you can remember it. But if you don't remember it, if you just draw this egg diagram, you'll straight away know how to differentiate the 2 causes of this lady's left gaze palsy. These are all lesions that are paralytic, so there is absence of stimulus, so therefore cannot look to the right. But if this is not a thunderbolt, but an electrical discharge here, then this frontal eye field is going to send barrages and barrages of signal to the 6th nucleus and going to push this eye continuously to the opposite direction. So that's why in your textbooks, you often talk about an excitatory lesion pushing the eyes to the opposite side, excitatory cortical lesion like an epileptic focus pointing to the opposite side, while a lytic lesion, okay, a hyperexcitable or inexcitable lesion like a stroke causing the eyes to be deviated to the same side. There are 3 ways of diagnosing this lady's problem. One is using the side of hemiplegia. The other one is to decide on the type of upper motor neuron or lower motor neuron facial weakness. There's a 3rd step, and the 3rd step requires you to touch the patient. Remember, the first one, hemiplegia, from a mile away, you know the diagnosis. As you come closer, you see the facial weakness, and deciding whether it's lower upper motor neuron, you will confirm your diagnosis, or rather you will further corroborate your diagnosis. But to confirm your diagnosis, you need to touch the patient and do what Dr. Z is going to do in this next picture.
Right at the camera, please. Right at the camera.
And he's doing a
So with the VOR, there's no real change.
VOR. Okay, so
camera.
VOR, there's no change. What is VOR? Vestibular ocular reflex. Okay, that's the technical term. A more commonly used term is the Doll's response. Doll's response or vestibular ocular reflex. So Dr. Z is saying with the vestibular ocular reflex, there was no change at all. So that means you're saying that the vestibular ocular reflex can be used to differentiate between this and this. So therefore, if the vestibular ocular reflex can be used to differentiate between this and this, then there's something missing in this diagram. What is missing? The vestibular component. What is the vestibular component? It's the 8th cranial nerve. So that means my diagram is incomplete. I have not included the 8th cranial nerve.
Right.
So we have to bring in the 8th cranial nerve to this diagram. So how can we bring the 8th cranial nerve to this diagram? How can we bring the 8th cranial nerve to this diagram? Okay. So many of you will know this by heart because you've learned anatomy. But remember, I said there are only two things in this whole lecture that I want you to memorize. One I've already used up. I've used up one trump card, which is that the frontal eye fields are crossed. Okay, you need to memorize this bit. Otherwise, you will not be able to sort it out. The 8th cranial nerve, how it's connected, you don't need to memorize. You can just work it out. Because if you now just look at me now, okay, basically I'm moving my head to my left. Okay, now this was a fast eye movement. Okay, of course, it could be voluntary, but it's a fast eye movement. So it's a reflex. Now, reflexly, what did my eye do? My right eye abducted and my left eye adducted so that I can continue to look at the green dot, which is the camera. Okay, now I decided to turn the other direction. I'm still looking at the camera. Now, of course, I can do it voluntarily, but this head movement, and throughout the lecture, you notice my head was moving, right? Up, down, left, right. So if I were to voluntarily think about moving my eyes, then I can't be concentrating on the lecture, right? Because my frontal lobe will be thinking about, oh, look to the left, look to the right, look to the left. So what the brain has done is, okay, why don't we relegate foveation when the person is otherwise active? Why don't we relegate foveation to a reflex? Okay, so that the frontal fields can be relaxed to do other things like give the lecture, talk to you, right? Because otherwise I won't be able to concentrate on what I'm going to say to you because all my frontal lobe is thinking about moving the eye. So what is this reflex? That is the vestibular ocular reflex. Okay, so how is it connected? Now you see, if I move my head to the left, okay, I move my head to the left, right? My right eye abducted, my left eye adducted, right? Correct? Now when I move my eye to the right, my left eye abducted, my left eye adducted. Now, semblance of what I'm just describing is already in this diagram. Semblance of what I'm just describing is already in the diagram. So as you know, in science, the nature always finds the easiest pathways, right? If the system is already there, why don't we build on that? So we already have a way of abducting one eye and adducting the other eye. And the control center is in the 6th nucleus. Okay, the control center is in the 6th nucleus. So when I move my head to the left, my right eye is abducting, my left eye is adducting. So which means which nucleus must be active? My right eye is abducting, my left eye is adducting. All I need to do is keep my right 6th nucleus active. Okay, and this movement is fine. When I move my head to the right, my left eye is abducting, my right eye is adducting. So all I need to do is keep my left 6th nucleus active then. So now we have sorted out the efferent part of this pathway. Now we have to think about where is the efferent stimulus coming from, the stimulus to initiate this movement. So now if you look at this, when I move my head to the left and I move my head to the right, now within my ear, there are semicircular canals. Okay, you remember from your anatomy days, there are 3 semicircular canals. One is superior, one is horizontal, and one is posterior. Okay, so the shape is horizontal, posterior, and superior. And these 3 are positioned behind this mastoid bone. Just behind this mastoid bone, they are shaped and like this, and they are angled in this plane. So if you look at my head now, my left eye, from my right side, my right ear, this is the superior semicircular canal. This is the horizontal semicircular canal. This is the posterior semicircular canal. Then if I turn my head to the other side, in my mastoid bone here, there's another 3 semicircular canals. One is pointing up, one is pointing back, one is pointing sideways. Superior, posterior, horizontal. So I have 3 semicircular canals on the right, 3 semicirculars on the left. So when I turn my head to the left, what is inside the semicircular canal? There's fluid. When you take a glass of water and you stir it, what happens? The fluid will move regardless of the receptacle, right? So in this case, the semicircular canals, when they're moving, the fluid is going to move within the semicircular canals because of inertia. And within the semicircular fluid, what is you have? You have hair cells. Okay, the hair cells are going to pick up this movement of fluid. Okay, that's how the semicircular canals transducts the movement of the head and sends a signal to the brain. So how does this signal work? Okay, for example, if I move my head to the left, the semicircular canal here, the fluid is moving, and there's fluid moving here also. But if you think about it this way, if you just think about it very simplistically, or rather very intuitively, if you move my head to the left, okay, where do you think the turbulence will be maximum? When I turn my head to the left, the fluid is moving in both semicircular canals, both horizontal semicircular canals on the right and the left. But here it has to move and hit against the wall. Okay, it's like waves crashing on the beach, right? It's going to hit against the wall and stop. Okay, while here this is moving away from the semicircular canal. So therefore, between the two, if you think about it, if I move my head to the left, which one do you think intuitively has got the greater signal? The left, where the direction of movement is, or the other side? Okay, if you think intuitively, you realize that when just like waves crashing on the beach, when you move to the left and stop here, the turbulence will be greater here compared to here. Okay, the turbulence will be greater here compared to here. When I turn my head to the other side, the turbulence here will be greater than here. So that is the afferent signal. So now let's think carefully now. When I turn my head to the left, we have already decided my right eye is AB ducting, my left eye is AD ducting. Which nucleus is active? Right 6 nucleus. Okay. Now, when I turn my head to the left, where is the greater turbulence? Left here. So what you need to do is connect the left ear, the left 8th nerve to the right 6 nucleus, and perhaps you should be able to effect the vestibulo-ocular reflex. Now you try it the other way. I turn my head to the other direction. The turbulence is greater here. My left eye is AB ducting, my right eye is AD ducting. That means my left 6 nucleus is active, but the turbulence was greater in my right 8th nerve. So connect my right 8th nerve to the left 6 nucleus, and we have effected the vestibulo-ocular reflex. So essentially, without learning to memorize, this vestibular dance would tell you that you need to connect the contralateral 8th nucleus to the ipsilateral 6th nerve to form the vestibulo-ocular reflex. Okay, so now you realize that to differentiate between a frontal eye field lesion and a 6 nucleus lesion for gaze palsy, you have one additional tool. You have one additional
Right at the
tool.
camera, please.
He's moving the head to the left and
Right at
right
the
and
camera.
see whether the vestibulo-ocular reflex. This is
So with the
not the
VOR there.
patient moving. No, this
Right
is
at the
the
camera,
doctor moving the
please.
head.
Right at the camera. So with the VOR, there's no real change.
So in other words, if I go back to this diagram, maybe I use this diagram. If the lesion was here, if the VOR is here and the lesion is here, when I do the vestibulo-ocular reflex for frontal eye field lesion, do you think the eye movement abnormality will be corrected? Yes, because the lesion is in the brain, is in the frontal eye field, is in the frontal lobe, sorry, not the brain, in the frontal lobe. Okay, while the vestibulo-ocular reflex is in the pons. So a lesion here will not affect the vestibulo-ocular reflex, and you will be able to move the head and overcome the deficit. While if the person's lesion is here, okay, then the vestibulo-ocular reflex is here. So therefore, this abnormality will not be overcome by the vestibulo-ocular or Dahl's response or Dahl's reflex. So that is the way we differentiate between the two. And now this is not a new concept. If you have a lesion in the cervical cord, your lower limb reflexes are present. In fact, they're hyperreflexive, correct? Because the lesion is above the site of pathology. But if the lesion is, let's say, in L3, L4, then your knee reflex will be gone. So if there's a lesion in the pons, your local vestibulo-ocular reflex is gone. If the lesion is higher up in the frontal eye fields, then the local reflex is actually quite normal. So that's how we can differentiate between a cortical lesion in this case and a brainstem lesion for this lady's left.
Right at the camera, please. Right at the camera.
So the absence
So with
of
the VOR, there's no real change.
there's no change in
Okay,
the eye
with
movement.
camera.
It's still difficulty looking to the left. So we concluded
Right.
that this patient's pathology must be in the 6 nucleus. So this lady has got a pontine cause for it. So in other words, you have 3 steps. As you walk into the ward, look for the site of hemiplegia. That will tell you whether this patient's left gaze palsy is it due to a right frontal eye field or left pontine lesion. Okay. As you come close to the bed and you can see the patient's face, appreciate whether she has got lower motor neuron or upper motor neuron facial weakness. If she has lower motor neuron facial palsy on this side, then we know it must be a 6 nucleus lesion on the same on that same side of the pons. Okay, but if she's got an upper motor neuron facial palsy on this side, then we know it's a contralateral frontal eye field lesion. Okay, then the third tool is for you to put your hand on the patient's head and turn the patient's head passively and see whether the deficit is overcome. If the deficit is overcome, then obviously it must be a frontal eye field lesion. If the deficit cannot be overcome, then we are dealing with a pontine lesion. So again, now when you go back to your wards and you see your middle cerebral artery infarction patients, you lift up the eyelids, the eyes are pointing. Let's say the patient has got a right MCA infarct, the eyes are pointing towards the right. So if you were to put your hand on the head and then you just rotate the patient's head left and right, you realize that now when you move the head to this side, okay, the eyes will, even though voluntarily is not moving there, but when you do it this way, you are able to bring the eye to the opposite direction, because by stimulating the right vestibular system, you are activating the left vestibular nucleus and causing the patient to abduct the left eye and adduct the right eye. So this deficit that was present, voluntary movement not there, but involuntary movement is there, will tell you that indeed this patient is looking at her own right MCA. End of the first section. Please email me with questions. In the next section, we will start off with a simple quiz, after which we will use the same egg diagram to figure out nystagmus. Hope you can join me. Thank you.